despite the fact that an allogeneic transplant is now a kind of core part of the therapeutic landscape for really all adults with AML, and many patients are now going to transplant as their definitive curative strategy. We know that between 35 and 60% of patients are destined to relapse, and if you relapse after an allograft, particularly in the first year, your outcome's really, really poor, and we don't have good, effective or well-tolerated salvage strategies. So the VIOLA trial, which was recently published in JCO, looked at combining azacitidine, which we know can be quite an active agent, with lenalidomide that also has ability to upregulate T-cell activity. That was a study that, first of all, established for the first time the tolerated dose of this combination. In fact, you were able to give quite a lot more lenalidomide than people had thought, and also demonstrated quite promising levels of activity, CR rates of in the region of 50%. So this presents a new, less toxic approach towards salvaging patients, and of course if they get into CR, they can go on to long-term survival either with a second transplant or DLI. So it's a really important unmet need, what we do for people who relapse after transplant. This was one of the first studies to identify a new treatment strategy. And of course, there's a number of very interesting drugs coming along. There's clear evidence that if you were transplanted for FLT3 positive AML, you have quite good responses to quizartinib or gilteritinib as salvage, but we need to start thinking about whether venetoclax or any of the other novel agents can be effective and well-tolerated strategies to get people into CR. But I think VIOLA does demonstrate these new agents can be quite active and is a promising area to pursue.